Yeah, okay, great. Thank you for having me. I thank the organizers for inviting me. I'm very pleased to talk about our experience in New York regarding newborn screening and Pompe disease. I have no disclosures. Uh, okay. So this is our outline for today. I'm just going to go very briefly on the background, but and mostly concentrate on the data from our state and also the medical center where I work at Mount Sinai, and talk about the burden of variant of uncertain significance and pseudodeficiencies that we've encountered, and go through the clinical experience of two highlighted cases. So, as we all know, Pompe disease is a recessive condition due to alpha-glucosidase enzyme deficiency, and that leads to the glycogen accumulation in the lysosome, mainly muscle cells. And so that then creates a muscular condition involving skeletal muscles, respiratory muscles, smooth muscles, but also, especially in the infantile stage of disease, cardiac muscle. The combined incidence of all the different spectrums of Pompe disease in U.S. is 1 in 40,000. So I just wanted to, as we talk about newborn screening, it's important to highlight incidence in our country and various different states. So as we know, there are two main types of Pompe disease that we've broken down into simplistic forms, the infantile and the late onset. With the distinguishing feature of hypertrophic cardiomyopathy in the infantile disease, and that can be detected at birth or sometimes even prenatally. And of course, there's an earlier onset of disease as well as a much quicker progression of disease. So we also know about enzyme replacement therapy for this condition that was approved in 2006. And this is effective at reversing hypertrophic cardiomyopathy in infants, which is the reason why for the implementation of newborn screening. And the fact that we know that there is low drug penetrance into the skeletal muscles, so trying to catch it early before skeletal damage, before we can cause irreversible disease, that was important as well. And the reason why for the low drug penetrance is because the drug enters into the cell and into the lysosome through an M6P receptor, the mannose-6-phosphate receptor, and there is paucity of this receptor on the muscle cells. So this is just to quickly highlight, newborn screening that was implemented in Taiwan because they have a higher incidence of infantile Pompe. The first article was sort of a pilot study, a proof of principle, starting in 2005, and then I'll just talk about the second article and the numbers that they showed us here. So this was published on the nationwide experience in Taiwan in 2013. Over 4 years, they have screened over 400,000 infants, of which 321 infants were screened positive and referred, 6 of which wound up to have infantile disease. And you can see here the incidence is about 1 to 2 in 100,000. So that's actually equivalent to about the same incidence of combined disease in the U.S. So you can see that heightened incidence in this country. Also, there were 20 suspected late onset Pompe disease. And then there were 294 cases of pseudodeficiencies. And we'll talk a little bit about pseudodeficiency and the burden of that, but you could see on this little graph the basic enzyme activity and how it overlaps with the levels that we see in people with disease. So, going into numbers, we started in New York State, October 2014. How it's done in Albany is the enzyme assay is done on tandem mass spec. All the samples are compared, and the percent daily mean is reported. If it goes below the 15% cutoff, then they reflex to a molecular analysis. And so when we get that referral call, we get both of that numbers and both of that data. So far, as of May 2013, the number of infants that were screened were over 600,000, 139 of which had a positive enzyme screening. And then the referred number was actually 97. So This number doesn't match this number only because we have the molecular analysis to help us. So you can see that the state does not refer patients who have only pseudodeficiency, and the state does not refer patients who have normal variants. So these are highly polymorphic variants that also is found to be in the lab to be enzyme attenuating. So you could also, if you remember from the Taiwanese data, they had about 400,000, and they had 300 infants referred for a positive screen, whereas we had a greater number of infants screened with a much less number of patients referred. So that was really great. So the outcome cases is that there are 3 infantile Pompe disease that have been picked up, 1 infantile onset of late onset Pompe disease, so I'll talk about that case at the end. We also have 16 infants with late onset Pompe disease with 2 known disease-causing variants, and 19 infants with possible late onset with 1 known variant previously described and 1 VUS. And then we also have 9 infants that had 2 alleles that were VUS in trans. And finally, we've had 30 infants with pseudodeficiency and a carrier 1 known variant, and 19 infants with 1 variant only, and these are just known to be carriers. So at Mount Sinai, when we get a positive referral, this is what we do. We get a history, physical, and laboratory that are geared toward looking at the muscle disease, evidence of respiratory issues or cardiac issues. We also get a urine hex4, which, if some of you guys don't know, is a biomarker for Pompe disease. We also repeat the enzyme analysis in our biochemical laboratory upstairs. Albany is great enough to do also parental enzyme assay and also molecular analysis for the parents, and that helps us, and I'll show you some slides on that. And then we also arrange for a same-day echocardiogram if we can, if we had seen that the results are concerning or suspicious for infantile Pompe. And we send CRIM status if the echo truly is positive and indicated that this is infantile Pompe. So I'll talk about the things highlighted in pink in a little bit more. So this is the enzyme assay developed by Chung-Li Yu at our biochemical laboratory upstairs in leukocytes, in which the group upstairs has been able to do, which is quite remarkable, is that they've been able to have different range of levels for infantile disease and late onset disease. You can see the other groups, there's also significant overlap, but it's helpful for me as a clinician for her to say, I think this is really infantile, and I think this is really late onset. But the other categories are pseudodeficiency and pathogenic, pseudodeficiency and VUS, pseudodeficiency and pseudodeficiency. Okay. I just realized the pointer that I was using is not working. Sorry about that. Okay. Okay, so the CRIM status is important for us to figure out how do we implement enzyme replacement therapy. For some of you that don't know, CRIM stands for cross-reactivity immunological material. CRIM positive means that these patients generally have a milder missense mutation that allows for some residual nascent enzyme, and they generally tolerate therapy well, whereas CRIM negative patients, they have deleterious mutations that do not allow any natural nascent GAA activity. And so unfortunately for them, almost always when you initiate enzyme replacement, it triggers the immune system into creating neutralizing antibodies and blocking the effect of the drug. So it's important to also know that irrespective of CRIM status, 80% of patients wind up with therapy to develop anti-drug antibody, and a sub-portion of them actually do develop neutralizing anti-drug antibody even if they're CRIM positive. So 40% of infantile and 10 to 15% of late onset people actually do to develop neutralizing antibodies as well. So the group at Duke has developed immune tolerance induction. So this helps prevent or lower the risk of the neutralizing antibody. So for CRIM-positive people, they recommend the methotrexate to be given 3 consecutive days within the first 3 infusions. And CRIM-negative patients, they do that same methotrexate protocol with rituximab. So rituximab, for those of you who don't know, it blocks the B cells and prevents B cells from growing, and therefore blocks antibody formation. And then because you do that in infants, unfortunately, they're going to be immunodeficient, so you have to give back immunoglobulins, IVIG, to protect them. So going to Mount Sinai numbers, 31 were referred to us for positive newborn screening, so that's about 1/3 the cases we saw in New York. And also concurrently, we got 1/3 of the infantile Pompe disease patient. So he's currently on treatment. There was one possible LOPD with 2 known disease-causing variant that is currently being followed. Currently, he is asymptomatic. We also have a lot of burden of pseudodeficiencies and VUS. So 14 infants with pseudodeficiencies and 19 cases, so that's 61% of all our referrals had at least 1 VUS. So going back to the previous line, we had 8 patients with at least 1 VUS and 1 pseudodeficiency. We have 7 patients with 1 VUS and 1 known mutation. We had 4 with 2 VUS, and fortunately, we were able to discharge 4 of them because of a normal repeat enzyme analysis, but 15 we're still currently following. We also found 4 carriers with 1 variant with normal enzyme activity, and so they were discharged. So I just want to highlight some of the learning lessons we got from variants of uncertain significance. So total, we identified 14 different VUS alleles in our cohort, and none of them so far have been associated with left ventricular hypertrophy in these patients. We actually found 2 of them that were recurrent in our families. So one is V22M, and that was seen in 4 families of South Asian, Trinidadian, and Guyanese descent. In EXAT, this variant was seen 108 times total, especially in the South Asian population, and 2 of them being homozygotes. And the allele frequency of this is about 0.6%. So right now, I think it could be a pseudodeficiency allele, but I'm not sure. So we're sort of on the fence about this one. It could be a late onset allele, but we just can't, inquire into the people who are homozygous in the database. So the other one is P690L, and that was seen in 2 families with Ecuadorian descent. And fortunately, there was 1 patient that was homozygous for this, and the enzyme activity was within normal range, and the patient was discharged. So this variant was also predicted to be benign in silico models. So we're pretty pretty confident that this is likely a pseudodeficiency allele. So just to remind yourself what pseudodeficiency is a variant that causes a depressed enzyme activity in the laboratory, but performs well in vivo. And this is mainly because we have identified people who are homozygous for this allele that do not develop any sign or laboratory symptoms of disease. And so the most common ones are G576S and E689K, and you can see overall allele frequency is high in the general population, but especially high in East Asians, which is why the Taiwanese cohort has such an issue with this. So I just want to pose a question out there and say, okay, so we know these are pseudodeficiencies, but what is the overall biallelic effect of one pseudodeficiency allele with another variant? Could that cause disease? And we don't really know. So unfortunately or fortunately, we'll eventually figure this out as we follow these patients. So this is sort of an extract of a large a database of things that we're just keeping in track, but it highlights the wonderful amount of data we can get from Albany. The first line is newborn screening, the proband, and then we could see the mom and the dad and the corresponding alleles that they carry. We can also see the enzyme activity in the parents compared to the baby. And so here's, in green is a VUS, in red is a mutation, and yellow or orange is our pseudodeficiency. So you can see a number of combination of patients that we see that unfortunately on repeat enzyme analysis, they sort of still fall within maybe the borderline high end of late onset disease, so we're continuing to follow with them. And as I said, we're following 15 of these. So far, none of them have evidence of muscle weakness or hypotonia. Only 2 had elevated CPKs. One, I think, is just a poor blood draw. And the other one, I think, is kind of worrisome. So I'm following this child a little more closely. We also were able to obtain urine hex 4 on 11 of these children. All so far have been in normal ranges. And we're trying to following them up every 6 months, although this child I'm following a little bit closer. Okay, so going to my experience with 2 cases I want to highlight. So this is a 10-day-old male. He was in the NICU at the time when the newborn screening was positive. He was in the NICU because of a twin. He was a twin, and they were born at 35 weeks. So he was found to have 2 previously known mutations. One was described in a supposed juvenile onset, and the other one was described in a child previously with infantile onset. The NICU was nice enough to give us an echo, and he really was discovered to have biventricular hypertrophy at the time with elevated CPK in the mid-300s. And they were able to send us a repeat enzyme prior to discharge. So we saw them immediately upon discharge, and you can see that the repeat enzyme activity was really quite low here, and Chung Lee had reported that this was in the infantile range. For our laboratory, his repeat CPK was 450 here, and his CKMB was also mildly elevated as well. And our cardiologist did confirm that they did see the ventricular hypertrophy. And so this is an infantile onset. So we did send the CRIM study at Duke, and this confirmed that he was CRIM positive. And we started enzyme replacement within two weeks of that first visit with methotrexate. And after 2 doses, the family decided to stop treatment, and I'll go into why that is. And then we referred them for palliative care. And the reason why this family decided to do that was they were highly informed. They were quite inquisitive. They did a whole bunch of research on their own, and they talked extensively with the Taiwanese group. So this was published like soon after they talked with the Taiwanese group, actually. I don't know about the timing of it. But there were 10 patients in that initial pilot study, if you remember. Now they have grown up at this point, and they've been followed for a mean average of 5 years. So you could clearly see that there was a good survival. The people in this pilot study were in red. These are natural cohort. These are the natural cohort without treatment. These are the natural cohort with treatment. And so obviously you see the benefits of newborn screening in these cases in terms of survival and ventilator-free survival. However, they did note that these 10 patients, while they all achieved independent walking, their gross motor skills eventually fell below age expectations. So this is x-axis, their age, and initially so this is a mobility score, age-appropriate mobility score. And so this is the mean. And so you can see that initially they were within age-appropriate level, and then eventually, even on treatment, they started to lose against their peers. Also, CPK started to rise, and so this prompted some of the clinicians that were treating these patients to increase the dose and frequency of enzyme replacement. They also noted that these patients started to develop facial muscle weakness, ptosis, and hypernasal speech, and 6 of them developed hearing loss. So in terms of the quality of life is really what this family is worried about, even with treatment. So they thought that he wouldn't ever be a normal child, and they were really worried about the impact of that. So that's why they decided to forgo treatment. So after they withdrew enzyme replacement, they continued to follow with us. And the echo at 4 months and 8 months actually did not show a significant increase in this in LVH, and it was relatively stable. And so we were all puzzled by this, and how long is it going to drag out, you know? So at age 9.5 months, he has significant hypotonia. He was, when he got URIs, he had a hard time clearing them. And his CPK and urine hex were trending up. And so they went for a second opinion to see Dr. Krishnani, and I was very thankful that they did, because she said that, you know, she's seen a couple of cases of these atypical infantile with a much slower progression of disease, and she felt that they have actually done quite well on ERT. And so because of this, the family decided to come back to us in terms of restarting treatment. So we started him on 20 milligrams per kilo every 2 weeks, and we've since had to increase that dose to 40 milligrams per kilo weekly, and I'll show you why. And so this is his CPK. You can see initially it was mildly high, and with the stopping of the ERT, it went even higher. And this is when we restarted, and you can see a decrease, but it sort of plateaued around here. And so we had to increase the dose to 40 per kilo every 2 weeks. And then plateaued again, or actually increased, and that's when we increased the dose to Q weekly. You can see the same sort of trend with the urine hex 4 increased while off ERT, and then went down nicely with the repeat of reinitiation of ERT. And then it actually increased again. So that also prompted us, combined information prompted us to increase the dose to Q weekly. Okay, and now he's actually 19 months now. He's walking and running independently. He has a little bit of lumbar lordosis with some hip girdle weakness. He's receiving PT, and the CPK has been low 300s, and his echo has shown improvement and normalization. Patient 2 is actually was not seen first at our referral centers, but another referral center. She had an 8% daily mean, and she was identified to have one allele of the late onset. This is a very prominent Caucasian allele that predicts late onset disease, and this is infantile onset truncation mutation. And so when she was seen at the outside, the other referral center, she had a mildly elevated CPK, and on enzyme analysis, her enzyme was falling within the late onset disease range, and urine hex 4 was normal. And so the referral center at the time said, you have late onset, and therefore let's just follow up and see how you're doing. So at age 4 months, the parents felt that she was floppy, and she had rolled over and then sort of lost the skill, and her CPK at the pediatrician's office was 490, so they were really concerned. They got an early intervention evaluation at age 5 months, and the AIM score, which is the Alberta Motor Scale, was less than 1 percentile for her age. And so they sought a second opinion at Duke at 6.5 months. They agreed with the low AIM score, and Dr. Krishnani in her note wrote that this was an atypical, very early infantile presentation of late onset Pompe disease. And she reasoned that because there is elevated CPK and motor issues indicating that there is muscle involvement, that this is a time to treat. Urine hex 4 still is normal. And so the patient came to our infusion center to start treatment. So we started her on 20 milligrams per kilo every 2 weeks, and we used the methotrexate protocol. So now she's doing quite well. She is all caught up in terms of an AIM score. She has been meeting her milestones on time, but there's still a little bit of ankle instability according to the physical therapist. She has developed a little bit of IgG antibody, but it's so far so good. It's very stable. And I'll just show you the trend for the CPK. So you can see this drastic improvement. Very, very nice graph. I couldn't even make it up better than if I draw it myself. So, so we're very, very happy, and the parents are very happy with this progress. So this is actually probably, the earliest treatment of a late onset case that I would say. So the lessons that we've learned is basically that recognizing diversity of our population, and that we will get VUSs, and the challenge of how to set up a clinical workflow to handle that. We also are recognizing that there is every single point along that spectrum of disease that we can find in patients. So recognizing an atypical infantile onset, not so quickly progressive, and also recognizing that late onset disease can present quite early. So trying to establish these follow-up protocols and treatment plans has been a big learning experience for me and my team, and just really trying to keep up with all the best practices has helped us in getting these patients to where they are. So I want to thank, of course, the patients and families, and my wonderful team at Mount Sinai. I can't do it without them, really. And additional help from Melissa Wasserstein, Joe Orsini at Albany, and Dr. Krishnani's group. I bug them like every other day with questions, and I've learned so much from them. So thank you very much.
It's a great presentation. I noticed that patient 1 was CRIM positive, but you did the methotrexate protocol anyway. Are you doing methotrexate for everybody just routinely, or?
Yes. So there was, sorry, I went very quickly on that slide, but there was a poster that was presented by the Duke that showed, here we go, by Dr. Kazi, that showed for the CRIM positive, it also makes a difference to just do that methotrexate to help lower that risk from the 10 to 15% to lower than that. So we decided to implement that for our patients.
Florida, we're going to start this soon, and we have emotionally quite a few worries about going into this, and your talk definitely doesn't make me feel better. I have a few questions. One is, you said you're following these patients. Are you following them? Who's following them? Echo by echo every year, and for how long?
Yeah. In terms of the VUSs, we do, depending on the enzyme activity level initially, we do that echo, and we do the urine hex for some of them, with the truncation mutation along with the VUS, and along with our cardiologist, we agreed for her to repeat that echo, but it's really kind of case by case depending on the enzyme and the molecular analysis hand in hand.
Is your intention to follow them into adulthood?
I hope not. Right now, we're saying every 4 to 6 months because they're still in this infant period and developing their motor skills, and I really want to make sure that they're hitting all their milestones on time. And so, I really want to follow them closely. But hopefully, as I want to see them at least, past age 3, and then I could be maybe a little bit more reassured that, if all their labs are normal, they're met their milestones on time, they're rambunctious, active kids, that, I could space them out to once a year after that. And then I'm hoping also at some point that we will all collectively have experience with these VUs and just resolve them for everyone.
So Melissa, who you mentioned, had reservations about Pompe screening when I talked to her. Now you've done this for a while. Do you think it's worth it?
Yeah, I actually do. Actually, I was a little skeptical about, because the case of the late onset Pompe disease that presented so early infantile, I actually was looking at her when they came to our infusion center. I was like, what are we doing exactly? Because I am not a physical therapist, and I couldn't see the weakness, actually. And it really takes an eye as a physical therapist to really plot her and see the difference. And I actually now could see the difference.
Yeah,
but
I'm sorry.
yeah.
I mean, if you send someone to physical therapy, I have grandchildren. I know they didn't meet all the milestones. I think if you send a normal child to physical therapy and say, does he have any signs of not meeting all the milestones? As you know, pediatricians don't use one milestone. but I think you're being very sensitive in terms of
Right.
deciding that this is infantile and changing it to infantile disease.
Yeah.
And, you know, CPK, you don't have a baseline, so unless you take them off it and show this, I mean, I'm not convinced. I mean,
I guess it's because I had struggled with this question at first too, but when I saw, the improvement of these children, so, when you're a pediatrician and you see a patient with delayed motor milestone, you typically just sort of say, okay, they'll catch up, and, if it's a CPK is mildly elevated, like, it's just mildly elevated. But then for this kid, the difference was by the time she came to us for treatment, her CPK was 600. So that clearly is abnormal. And the fact that 2 independent physical therapists had said that she had a very low AIM score also sort of convinced me to start. And the improvement that I saw made me feel good about our decision. Okay, thanks.
So in the last
Okay, yeah, okay, great. Thank you for having me. I thank the organizers for inviting me. I'm very pleased to talk about our experience in New York regarding newborn screening and Pompe disease. I have no